want to thank everybody tonight for attending. This is something kind of new to our community. We're trying to combat the crisis in the opioid and heroin field, I guess you'd say. Different approaches have been tried in St. Genevieve, and it's just not made it. We've struggled in the past trying to get things going. And talking to Nicole, I've been to Nicole's meetings before, her seminars, and she's a great speaker. I can't wait for her to take off with it, because you guys are going to just be amazed, and you're going to go out of here with a lot of good information, a lot of new information. But first, I got to take care of a little business, and that first of all, I want to thank my partner in crime over there, the big woolly guy. You want to come up here with me? Yeah, come on up here. This is Trent Ely. He's a business agent for our local. We're Labor's Local 830. He's a business manager. I'm the president of the local, and this meeting is a gift to our community to help our community to get educated. So, like I said, in the past we've had problems not being able to know where to go. We've been trying to treat people who have been addicted, and there's a very limited resource. We can send them out of town. Now we've got some people coming in town, but that's kind of what I call, and I just talked to Nicole tonight about that. I kind of looked at that from a bottom-up type of approach. And so if that's not going to work, maybe we need to start from the top down and educate people who aren't in trouble yet, and maybe they can educate people that need educated. So that's going to be my approach, and I'm hoping that this gift, this first meeting we have tonight, will move forward and spur more meetings. No one's ever heard her speak, Nicole, in front of you. And I was really pleased that the community center is allowing us to have this meeting up here, not knowing anything about it. They said absolutely no problem. So I'd like to give thanks to Joanne Luttrell and Brad Arnold for allowing us to have this up here. It's a nice neutral location. It represents health and well-being. And then, of course, I had some people that endorsed this right from the beginning, never knowing what we were going to do, how we were going to present it. I didn't know how I was going to present it, quite honestly. The first person I talked to in this was Mayor Hassler. Mayor Hassler said, absolutely, I'd be more than happy. So, and Sandra Bell, she's with the County Health Department. She's the administrator. She came on board right away, and she's been trying to get this community some help. Chief of Police Eric Bennett, he just recently came in and endorsed the program. So, we're moving forward. We're trying to open some eyes. We need to get rid of the stigma that people are having problems and deal with it. We're never going to solve the problem until we're ready to deal with the problem. I'm going to turn this over to Nicole and let a true speaker speak.
Thank you. Thanks, Bill. And I pace, so I don't like holding on to something while I have to talk. So, my name's Nicole Browning. I'm here. I work for NCADA. My guess is none of you have heard of NCADA before. It is St. Louis based and located, so I'm out of St. Louis. Our agency is a prevention agency primarily. We're in schools, ages K through 12, talking to kids about drugs and alcohol. And then we also have a small counseling department that I'm the director of. So we have 5 counselors who do assessments and referrals. We do not provide treatment. I'll talk a little bit more about that at the end. And then we have a small department that goes out into the community and does these kinds of presentations. So I'm here on behalf of the MoHope Project. What that is, really long, that's the reason we shorten the word. It is the Missouri Opioid Heroin Overdose Prevention, Prevention Education Project. So it has been around for about 1.5 years now that we've been doing kind of these presentations. Really long story short, what happened was SAMHSA, which is a federal entity, they are the Substance Abuse and Mental Health Services Administration, realized we need to do something about the opioid crisis, right? So they gave 11 states some money. Missouri was one of the 11 states. What we're doing with that money is educating people about heroin, opioids, and Narcan, or how to respond to an opioid overdose. Because we know we're in a crisis. This is happening everywhere. So the idea here today is I'm going to talk about this opioid crisis. We're going to kind of do a heroin 101 so that everybody has the same base knowledge. And then we're going to move into how to recognize an overdose and how to respond to it properly if you're in the situation where you may come across one, okay? I talk pretty fast. I'm a counselor by trade, which means I like human interaction. So please ask questions along the way. This is heroin, right? This is what we think of as heroin, especially those of us probably over the age of 30, right? You picture a needle, a syringe, a spoon. But really, this is heroin of today. One of these is heroin that was seized by St. Louis County. One of these is glucosamine chondroitin, over the counter for the joints, right? So the one on the left, the kind of green and white pill, who thinks that that one is the heroin? Raise the hands. 1, 2, 3, 4 of you. Who thinks the one on the right is the heroin? Like 5 of you. Some of you might have raised your hand twice, right? Who's really sure of which one's which? The 2 guys have seen the presentation before, right?
I'm saying the one on this side.
You think the one on the left is the heroin? You are correct. The one on the left is the heroin in this case. But for most people, they're like, I have no idea, right? Because we are a society that we take pills, we take over-the-counter stuff, we take supplements. Pills are not a big deal. The point here is that historically, when you saw this, even if you were drunk or a little high, or maybe you might snort or smoke something, you weren't going to use a needle, right? That was a barrier. But today, heroin is strong enough that you don't have to go there, especially not in the beginning. So we're going to talk a little bit more about that progression as we go. But I want to give you just a brief background of why I'm here and what we're looking at. So this is probably really hard for most of you to see, right? So the most notable thing here that I want you to see is this ongoing line, right? We know that we've had a crisis where people are overdosing. But this one specifically right here, this one is heroin, okay? So this line kind of started spiking in 2010, 2011. The one that you can all see is this bright blue one, right? That skyrockets right at 2014. That's fentanyl. You all have heard of fentanyl, probably. We're going to talk a little bit more about it in case you haven't. But the most notable thing here is all the trends are pretty consistent, right? But those couple of spikes are the reason that we're here. Those spikes in opioid overdose deaths are the reason that we're here. Those are national numbers. The closest I can get you, because I focus in the eastern region, right, is this regional information. The eastern region is St. Louis Metro, right? So that's St. Louis City, St. Louis County, Franklin County, Jefferson County, St. Charles County, Warren County, right, that eastern region. So then when you look at the other areas of the state, there's the central, we're down here in the southeast, southwest. So they're not nearly as impacted as the eastern region, but it's still impacted, right? There are still numbers on the screen for anywhere that you live in the state of Missouri. I mentioned that eastern region. The really big bar at the bottom, that's St. Louis City. So that's where overdose deaths are happening, and that's where they are the most common. This makes sense, right? People assume St. Louis City. What you're not thinking about here, though, is that number is artificially inflated because people go to the city of St. Louis to buy their heroin, they use their heroin, and that's where they overdose from their heroin. They don't necessarily live in the city. So if you adjust that for population, that's the other few lines. The next 2 lines that you see up there with the highest overdose rates are Jefferson and Franklin County. Not by any means the city, right? So a lot of people get surprised by that. They don't expect to see a little bit more rural areas to have those kinds of numbers. The next numbers are St. Charles County, St. Louis County. So Jefferson and Franklin County have more overdose deaths than even St. Charles and St. Louis County do. That's a little surprising to most people. The reason we're talking about Missouri, because we have a problem. St. Louis is the 6th in the nation for overdose deaths. This is fentanyl down here. The vial on the left is a lethal dose of IV heroin. The vial on the right is a lethal dose of IV fentanyl. For those of you towards the back half of the room, my guess is you probably can't even see the fentanyl in there, right? It's just a few grains. That's really important to know because fentanyl is lethal. That's what killed 70% of the statewide overdoses in 2016. We don't have final numbers for last year yet, but we know in the St. Louis area, that was about 80% of the deaths was from fentanyl, okay? So fentanyl, who has heard of or knows what fentanyl is? Okay, about half of you. So the fentanyl you may know about or have heard of is like end-of-life cancer, like there's a fentanyl patch, right, that someone who, if they're dying, gets. Or there's like a fentanyl lollipop that people can suck on, and this is a painkiller, right? It's an opioid. This fentanyl is not that fentanyl. The fentanyl that people are using now and overdosing from is illicitly made fentanyl that's coming from China. Most of it comes from China. Either goes to Canada or Mexico and comes up our existing trade routes. So it's this white powder form, looks just like heroin, okay? And it's stronger than heroin, about 50 to 100 times stronger than heroin. And if you've heard of carfentanil, it's the newest. It's called an analog of fentanyl, so it's just a little bit of a different makeup than fentanyl, and it's even stronger. It's known as the elephant tranquilizer, right? Because that's what it's been used for in the past, is to put elephants under when they need medical stuff done to them. So that's how strong it is. All right, so I mentioned once that we are a nation of pills, right? We go to the doctor, we pay our copay. If I wait for 20 minutes and pay my $20 copay, I don't want a pat on the back and drink plenty of fluids, right? I want a prescription so that I can feel better, right? So in America, we are 5% of the world's population. We have 80% of the world's painkillers and 99% of the world's Vicodin. That's a crazy amount of pain pills, right? I see some shaking heads, right? Like, that's enough for every man, woman, and child in this country to be on painkillers for 24 hours a day for a month. So why is that relevant? Because 2 out of 3 heroin users started with prescription pain meds. I still see nods, right? Why would someone switch from a prescription pain med to heroin? It's not strong enough, it doesn't work, their doctor cuts them off. Easier and cheaper to get, you covered all the bases. Yeah. So I don't know about down here, can any of you tell me if I were, say, misusing my Percocet or my Vicodin? I get cut off, I can't get it anymore. I can buy it on the street, right? Sure. Anybody know how much that is around here? $10 a pill. For a prescription pain med? For Oxy specific, okay. That's cheap, right? I saw that face.
Cheaper than that.
Vicodin 10 milligrams are usually about $7.
Okay, so 10 milligrams. What about something stronger?
I don't know, a couple years ago.
Okay, okay. That kind of makes sense. So 10 milligrams, around 10 bucks. Usually, it's about $1 a milligram. So if it's 10 milligrams, 10 bucks. But if you're getting a 50 or 100 milligrams, it's 50 or 100 bucks, right? How much is heroin here? $10. $10. $5, We here in St. Louis, strong and steady, 5 to 10 bucks. Columbia, Missouri is about 20 bucks, so I was wondering if it's a little more here, because some people like to charge a little extra for the travel, right? But 5 to 10 bucks, 10 to 100 bucks for prescription pain meds. Which one's easier to find?
Heroin.
Heroin, I heard it ×3, right? Accessibility and cost. You all know about the PDMP, Prescription Drug Monitoring Program. Have you heard of that? And the fact that Missouri is the only state in the nation without one, right? That plays a part. I mentioned Franklin County. Franklin County is still not part of that PDMP that we have created. So it's real easy to jump on the highway and drive to Franklin County, right? To see a doctor, to fill your script, to do whatever you need to do to get a prescription. I'm going to talk about addiction. I'm going to talk about substance use disorder. What you will never hear me say is the word addict. Why would I not say the word addict? Stigma. When I say the word addict, what do you picture?
Back alley shooting up.
Back alley, shooting up. Usually bad skin, maybe dirty, maybe homeless, right? People usually picture that person. They don't picture a 20-year-old kid. They don't picture a stay-at-home mom in a $500,000 house with a white picket fence, right? Because it carries the stigma, and I'm really happy you talk so much about stigma. What I didn't hear you say is prejudice, right? Because prejudice doesn't exist without stigma. It's the stigma that we have about certain things that creates this prejudice that goes along with it, right? So that's why we really have focused on teaching people about this brain disease and about the fact that it's a disease, not about bad choices or bad people. The AMA says you need these 3 things for something to be considered a disease. It needs to have clear-cut symptoms, a progression, and a prognosis. Other diseases that we know a lot about, things like diabetes, heart disease, hypertension. We know when somebody has certain symptoms that maybe they should go get their blood sugar checked, right? Because we know those symptoms really well. We also know the progression. We know that if you're diagnosed with diabetes, that you should change your diet and exercise. And if you don't and you have to take insulin and you don't take your insulin, we know that progression, right? We know where that goes. We know that path. Substance use disorder is the exact same thing. So as a clinician, I have been a LPC, a licensed professional counselor, for about 12 years, right? I've always worked in the substance use field. So for me, it just kind of comes pretty quickly, like I know what to look for, right? Those symptoms that I'm looking for are things like you set boundaries for yourself that you're unable to maintain. So maybe that means you are going to go to happy hour and have a couple beers. And the next thing you know, it's the next day and you don't know how you got home, right? Usually when I say that in a crowd, like, so I train police, I train emergency responders, I train social service agencies, and then this is what we call general public, right? So usually in those more professional group meetings where they're all coworkers, somebody like nudges somebody, they're like, that's what you do, right? It happens to all of us, right? But when it's a pattern, then I become concerned. Maybe that broken boundary is your 30-day supply of Vicodin only lasts you 2 weeks, right? It's things like continued use despite negative consequences. So you get a DWI and you keep using. You get in trouble at work. You get written up at work. You get suspended at work. You get fired from work and you keep using, right? As it progresses, the things that I'm looking for that I know are red flags for addiction are tolerance and withdrawal, right? Tolerance meaning it takes you more and more to get intoxicated. Withdrawal meaning you have some sort of response when you don't have it, okay? Make sense? All right. So if we can accept that it's a disease, then we know that this happens to anyone and everyone, right? It's in every neighborhood, it's in every town, it's in every family. I didn't do a head count, but if there's 30 people in here, stats show that at least 10 of you are affected. Now, y'all might be here because you're affected, right? But in general population, 1 in 3 families are affected by substance use disorder. So that's pretty prevalent, whether that's marijuana, alcohol, or opioids. All right. For those of you who can't read the list, I'll kind of run through these, but these are risk factors for substance use disorder. As I go through them, I want you to think about what you think is the best predictor. Victim of abuse, it's easily accessible. Poor self-concept, difficulties coping with stress, weak family relationships, early experimentation, behavior problems, and genetics. We know that these are all risk factors, but one of them is more likely than any of the rest to lead to substance use disorder. What are your guesses? What do you think is the best predictor?
Early experimentation.
I heard victim of abuse, early experimentation, coping skills. I didn't hear the most common answer.
Genetics.
Genetics, there we go, yeah.
See it in alcoholics. You see it in lines of,
Yeah, generation after generation, right? Because we know genetics is real. We know if you have a parent who's addicted, you are 4 times more likely to be addicted yourself. Absolutely. So the number 1 answer was early experimentation. So why? How old are you when your brain stops developing?
25.
25, yes ma'am. So if I introduce substances to my developing brain, it's more likely to become addicted faster because that brain is still developing, and it learns to rely on this substance because the substance becomes my coping skill, it helps my self-concept, right? It does all these other things too. So that early experimentation doesn't just mean opioids. It means I snuck my mom's vodka and smoked my brother's weed at 13 years old. When someone starts experimenting at the age of 13 or younger, 70% of them go on to develop a substance use disorder in the next 7 years. So that means if I'm just smoking a little weed a couple times a week at 13 years old, by the time I'm 20, most of them are going to be addicted to something. And I see this after having done this for many years. Some people think 11 and 12 sounds crazy young, right? But I'll tell you, 90% of the time when I ask someone in my office, how long have you been using? What age did you start? I always hear 10, 11, and 12 years old. Always. It's very rare that I hear them say 18 or 21, right? Because of that progression. So that's where when people start saying this is about bad choices, it's a struggle for me, right? Because when I was 14 or 15, did I make good choices? Probably not. Did all of you make the best choices at 17 or 18? Probably not. Usually there's one guy who's like, I did, right? But most teenagers don't make good choices because of that developing brain piece, right? That's the last thing to develop is the frontal lobe, which is decision making, thinking about consequences of your actions. This is why teenagers do stupid things, right? Introduce substances and it's even worse, right? So especially if I have several of these things going on and I start using early, I'm in trouble and I don't even know it, right? So I once was doing a training and a guy became very angry at this section and crossed his arms and he's like, I've had every single one of those things happen to me, I'm fine. Sure, because of something called protective factors. So I like to call that the bubble wrap. So maybe you were the victim of abuse, but your parents got you into therapy. Maybe your family is awful and it's in your genes and it's easily available and drugs are there and it's acceptable in your family, but you spent all your time with your best friend and their parents treated you as their own and you were involved in school and in sports, right? All the things that help protect you or kind of counterbalance the negative stuff. Just like someone can have none of those and still develop that brain disorder, right? Because it can always happen. The other thing that's not in here that I like to mention sometimes is mental health that can come into play here, especially if you're a young person. Maybe your family doesn't know, maybe you don't know, maybe there's something underlying there like depression, and you are 15 years old and you take your first drink, and it's the first time in your life that you felt good. When I ask people why they use, people are like, because it feels good. But when someone says, I used to feel better, that's my red flag that there's a mental health concern. Because when we have a couple beers, we used to feel good, we used to relax, right? When someone has a couple beers or smokes a little weed or takes whatever they're taking to feel better, it's because they don't feel good to begin with, right? So usually that means there's an underlying mental health concern. Speaking of feeling good, let's talk about what this stuff does to the brain. So dopamine is part of our reward system. It's part of what makes us feel good. There are certain things that when we do them, we release dopamine. Everyone right now is fully awake. What, 6 o'clock at night? This is impressive. So you're at 100% fully loaded on your dopamine. Whatever your level is, you're at 100%. So if you grab some dinner on the way or you're looking forward to something tonight, right? Like part of that excitement about food is dopamine. You get a release of dopamine. So you go from 100% to 150%. You get a little bit of a boost. I like to joke that if you're doing it right, sex is better, right? You go to a 200% boost of dopamine. And then there's nicotine. Anybody want to admit to being a current or former nicotine user? Several of you. Okay. Who has ever tried to quit? How many of you quit the first time you tried? Look at you! You're like the 3 exceptions to the rule. But like, usually there's 1 or 2 people that quit the first time. Most people, when they quit nicotine, it takes them 3, 4, 12 times, right? Or they got nicotine gum in right now, or they're stepping outside right now for some fresh air, right? What happens is when you use nicotine, you get a boost of dopamine. It goes up to 215%. It's rewarding. We know that cocaine is addictive. That gives you a 300% boost in dopamine. And then there's heroin. That's 2,200 times normal. That's a big deal, right? You all have heard of that term, chasing the dragon. That's your dragon. That first use, people say, is indescribable. It's the best feeling you've ever felt in your whole life, and nothing else can get you that way. The problem is, you hit that 2,000, so you use again, but then you only hit 1,800, then you only hit 1,500, then you only hit 1,200, then you only hit 900, then you only hit 500. You never get there again, right? The other thing that happens is your brain cannot deal with all that dopamine. So it does something called synaptic pruning, where the receptors stop accepting dopamine. And then, because you're giving it all this dopamine from the outside, it stops making its own dopamine, which means nothing else in life feels good anymore. You don't care about anything else. It changes how your brain functions. It changes the structure and the chemistry of your brain, which is why it's a brain disease. So here's what that looks like. For me, when I saw this chart, it clicks for me. So the first time you use, you get really high, and then you get not as high. And then right here, that's where your brain has stopped making dopamine. So then you crash. This red zone here, that's dope sick. You all have heard the term dope sick. It's the flu times 100, right? You have diarrhea, you're vomiting, your body feels like it's on fire, you're hot, you're cold, you're sweating, you're miserable. So what do you do to feel better? Use an opioid. Because then you're using to feel normal, right? So you crash, you use to feel normal. You crash, you use to feel normal. What you also notice on this side of the screen is that they're not getting high anymore. There's no more euphoria. So someone in active addiction to an opioid, they wake up, they feel dope sick, they use to feel normal, to not be sick, to bring themselves out of dope sick. They're not getting high. They can't get high, right? So that's where that cycle comes into play. Make sense? All right. Let's talk about medications for opioid use disorder. People generally have pretty strong thoughts and opinions when they hear the word methadone. Well, I like to talk about it so that we can bust any thoughts that are out there and talk about it really honestly. So these are the types of medications that are used for opioid use disorder. I'm going to cover them really briefly, and then we'll see if you have questions. The two on the left are opioids. So methadone and buprenorphine. Buprenorphine is often known as Suboxone. That's the name brand. They are both opioids. The one on the right is naltrexone. It's most often given as a shot form called Vivitrol. That's the name brand for it. So what these do in the brain, I mentioned both of these are opioids. So they go to the same receptor in the brain. Any opioid goes to the mu receptor in the brain. So that mu receptor receives Vicodin, heroin, fentanyl, methadone, and buprenorphine. These all go to the same receptor in the brain. Methadone goes to that receptor, fills that receptor, makes the person feel like they're not dope sick anymore. If taken appropriately and as directed, then they're not high either, okay? It can be misused. They can get high on it. They can overdose on it. The buprenorphine goes to the same receptor in the brain, activates the same receptor, and it creates what's called a ceiling effect. So when you're on the right dose, you don't get high, and it keeps you out of dope sick. It can be misused, but it's a little harder to misuse, and it's a lot harder to overdose on because of that ceiling effect, and it doesn't slow down your respiration the same way, which is why overdoses happen, okay? And then the naltrexone is a blocker. It blocks that receptor, goes to the same receptor and covers it up and blocks it. So if it's the Vivitrol shot, that shot lasts about a month, okay? So pros and cons to them all. These are opioids, right? The one on the right that's about a month shot starts to wear off around day 23, 24, 25. The cravings come back. People struggle for those next few days until they get their next shot. Some places, depending on where you're getting your shot, will give you buprenorphine to bridge that gap from like day 25 to 30. As far as the opioids go, the purpose of any three of those medications is to take someone out of this and keep them in that normal phase, right? It's to keep them out of the dope sick, I need to feel better, and keeps them in that maintenance phase. So then the question becomes for most people, does the brain heal, and how long do you have to be on the medicine? Because that's the struggle with methadone for a lot of people is they believe, and I will say myself included, for at least the first 10 years of my career, it's a substitute. I was a firm believer in it's the exact same thing as heroin. You're just giving it to them every day. For me, learning a little bit more about the science and seeing this was helpful to move me on board, right? Because when you take it as directed and you're on the right dose, it keeps someone at normal. Because what happens is when they're in this cycle, nothing else matters. I can't do therapy with you. You don't care about getting a job. You don't care about the legal system. You don't care about your kids, right? All those things fall apart because you're just worried about not being sick. So if you can be on an FDA-controlled substance that keeps you in maintenance phase, that's how you can do all the other stuff. Science and research says that this is the best way to treat opioid use disorder because someone's brain may never heal. So it depends on the person. It's really individualized. If I was that 13-year-old who started on this path and my brain never developed properly in the first place, it's going to be a lot harder than if I, in my 30s, get addicted and then stop, right? If I'm addicted for 6 months and stop versus someone who's been addicted for 10 years.
Is there any study or success rate on somebody that's on this and is steady, that is getting treatment? Are they doomed to be on this the rest of their lives, or is there an opportunity to get off of it?
Both.
Off of that?
Both. That's where it depends on that brain development. So that's why some people are on methadone for 20 or 30 years, is because as soon as they get off of it, they fall right back down. And if they're on the right dose, they're not getting high anymore. They're just having enough to feel normal. And Suboxone is, so methadone has been around for like 50 plus years. Suboxone's been around for 15 or 20. Yes?
What happens if you do heroin or something while you're on methadone?
You're going to overdose and die. Maybe die. Which happens, which is why everybody wants naltrexone. Everybody's like, let's just give everybody naltrexone because it's a blocker, right? Because if you use an opioid while you're on naltrexone, you can't get high, you can't overdose, unless it's towards the end where it's wearing off, and then you're more likely to overdose because you've lost your tolerance.
Isn't Suboxone the same way though? It's an opiate blocker?
It's a partial blocker. So Suboxone is a partial blocker. So it is possible if you use enough to still overdose. Yes. And a lot of people don't know that because it's what's called a partial agonist. So methadone is full, Suboxone is partial, and then naltrexone is actually an antagonist. It has naloxone in it and blocks that receptor for a long time. But you can still overdose while you're on both of these. The part here, I was actually just at a conference in Atlanta, this really big national conference where the Surgeon General put out this advisory about everyone having naloxone. So one of the doctors there that I went to a couple of his sessions talked about buprenorphine specifically because this is something I want to know more about because it's my weak point, right? And not knowing as much about it, I'm not a doctor, so I need to know more. So what he talked about is for him, he has had thousands and thousands of patients, right? And every time he weans them down to their lowest dose, and then he's like, he says about half the time when he takes them off, they go right back to it because their brain doesn't heal. And we don't know how long it takes to heal. And then what happens is the experts who do all the research, so NIDA and SAMHSA say that the go-to answer is you should be on it as long as it takes, minimum of 1 year. So theoretically, you're going to counseling, you're getting a job, you're kind of putting your life back together while you're on this medicine, learning coping skills that you may not know or have forgotten about, and then when you stop taking it, you can kind of deal with life as it comes, unless your brain hasn't healed, because opioids do so much damage. Since I've admitted, I've struggled with medication like this in the past.
I'm with you on that.
It's a struggle, right? So here's the example that someone gave to me who was in the audience. It was not a peer. This was someone who was learning about this stuff. She's actually a paramedic. And she shared with me, she said, you know what this reminds me of? She, I would guess, is in her mid-40s. And she said, you know, I was always fine my whole life. On my second kid, I got postpartum depression. I got on antidepressants. I felt better. What do people do when they feel better? They stop using it, right? So she got off her meds. She's like, I went right back, crashed. Her red zone was depression. I didn't care about work. I didn't shower. I didn't want to do anything in my life. So I got back on my meds. She's like, my kid's going to college now, just so you know. And I've had to maintain those meds. So some people, even when things like depression or bipolar, especially depression, right? Sometimes it's chemical. You have to be on it forever. For some people, if they get on an antidepressant, they go to therapy, they get a new job or a new spouse, or their kids move out, or whatever the stressors are, right? Then they can stop the medicine and they're okay. So for each person, it's a little bit individual, and it's the same thing here. Yeah, with opioid specific, with cold turkey. So let me throw a couple stats at you. With other diseases that we know about where medication is required. So for hypertension, for diabetes, and for high blood pressure. For people who are supposed to be on medication for that, there's about a 50% relapse rate. People forget their insulin, people forget to take their pills, right? With substance use disorder, for opioid specific, people who take medication for their substance use disorder, there is a 10% relapse rate. For substance use disorder who do not take their medication, there's a 50% relapse rate, just like any other disease. For people who stop cold turkey, don't use any medication, there's about a 50% relapse rate, just like other diseases.
It's not too bad considering.
Unless that relapse leads to death, which we're going to talk about in a second, because once you're sober, you're more likely to overdose from opioids specifically. And I'm going to get really into that in just a second. Yes, ma'am?
I think we're part of the medical
Yeah,
community.
yeah.
But as far as long-term use of the treatment medicines, what they're telling us is there's many, many studies that show using the medicine to prevent relapse is supported by evidence.
Yes, by and large.
Using the medicine
Yeah.
is not supported by evidence
Yeah.
right now. So
Yeah.
they being the
Medical experts of the world.
are supporting
Yes.
long-term use
Yes.
of naloxone or naltrexone.
Yeah, and the movement has even become medication-first treatment. Historically, we've tried to get people into talk therapy treatment, and then we can give them the medicine too. Now, the movement in the last year has been get them medicine, get them medicine, get them medicine. If they want to go to talk therapy, great. But that's almost become secondary now because that medication is so important. Thank you.
And also, a diabetic who has suffering with the disease, you do not take medicine away from them, they need it forever. A drug addict who's suffering from disease, you don't take medicine away because they need it forever.
That's a great example, and we sometimes talk about that, and I'm glad you said that instead of me saying that, because that's what happens too, especially when we talk about insurance coverage too, right? Like, sometimes we want to send somebody to 2 weeks of treatment or a month of treatment, or we'll cover their medications for 30, 60, 90 days. We don't cut off a diabetic from their insulin. They just have to keep taking it because it's part of that chronic, ongoing disease. Yes, sir? There's a lot less stigma, yes.
So I'm
Yes.
sold, what I've heard tonight, I'm sold on that medication for
Okay.
the person.
Okay.
Now, what about the person that doesn't have insurance? How much does that cost, and how can they get the medication? I mean,
Yes.
and not that you can't
Yes,
do that.
I can.
Problem.
Yes, it is.
For
Yes.
that long term, maybe I would hope that they get a job and then they get insurance and they can pay for
Mm-hmm.
it, but, I mean, what about right now?
All right, so out here, it's a lot harder. Let's be honest. St. Louis area has a lot more resources. We don't have enough. So part of what I do in my job at NCADA, because we don't have treatment, is people call us every day. We take like 20 phone calls a day. If you're paying cash in hand out of pocket, you don't have insurance. You pay for methadone, it's the cheapest. It's like $5 to $10 a dose. This is like $20 a dose. This is $1,000 a shot.
Last a month.
It lasts a month. A lot of insurances don't cover it. I'm about 98% sure that in my slides later on, I'm going to talk about treatment access. So I'm going to cover the rest of your question in a minute.
And if you use oral naltrexone, it's much cheaper.
Yes, it's just hard to find. Yeah, it's happening a lot less. That's why I always talk about Vivitrol. Oral naltrexone exists, just like there is now a shot of the buprenorphine too. There's a long-term acting buprenorphine too. It's just not very commonly used. So hopefully that's part of what they talked about at that conference in Atlanta is more access to medication and making it more cost effective so that more people can access it. Good questions. Okay, so let's talk about that overdose piece a little bit, and then I'm going to talk about treatment. So these are risk factors for an opioid overdose. The things on the left side are the chronic ongoing risk factors. So these are things that if you know someone well, you're going to know they have these risk factors. You're going to know that they've had an overdose in the past, that they have a substance use disorder, that they have access to pain meds. The right side of the screen are the really important ones I would love for you to learn about today. And if you take anything, don't take anything else, take this piece. The very first one, so the acute in-the-moment thing that you can assess for, the very first one says a period of abstinence equals a decreased tolerance. Whether I have been using Vicodin for 6 months or heroin for 2 years. If I stop cold turkey, how long does it take me to lose my tolerance to opioids? What are your guesses? A day? Okay. A week? I heard a week.
A week's about right.
A week is about right. Okay. A week is about right. Most often common answer I hear is 30 days. Most people say 30 days. Some people say a couple weeks. A guy I trained earlier this week said, well, if you've been using for 2 weeks, it should take you 2 weeks. If you've been using for 2 years, it should take you 2 years. Any opioid, doesn't matter how long you've been using it, 3 to 5 days. So less than a week.
And age, none of that.
Age doesn't matter, gender doesn't matter, size doesn't matter. It's across the board, which is so different than everything else, right? Like when it comes to alcohol, your tolerance versus my tolerance versus your tolerance are all different. Once you establish your tolerance, you maintain it pretty well throughout your life, right? So opioids is very different, 3 to 5 days. From the varying audiences that I train, oftentimes medical professionals, I just trained paramedic and EMT the other day, there were 12 of them in the room, not a one of them knew. The only people who sometimes know are people who have worked in a detox or been through detox, right? Because it takes about 3 to 5 days. So what that means is, I get arrested on Friday, I spend the weekend in jail, I get out on Tuesday and use what I used last Tuesday, I'm gonna overdose. It means I quit using cold turkey. I've been sober for 6 weeks and I have a relapse. Substance use disorder is a relapsing disease. Most people relapse at some point in time. Usually when people relapse, they use what they used last time, and they're more likely to overdose. So those are the people at most risk. So that's where it becomes scary, because if someone has a relapse, I want you to be able to come back to treatment, talk to your therapist, talk to your sponsor, talk to your family, figure out what happened and address it, right? Not die from it. 3 to 5 days. Change in purity or fentanyl, right? We kind of already talked about this. Heroin of today is not heroin of 10 years ago. Heroin of 10 years ago was less than 30% pure, often around 5 to 10% pure. Heroin of today in St. Louis County is 50 to 80% pure. It's crazy strong. That's why you don't have to inject it anymore to start that process. You can smoke it or snort it because it's so much stronger. And then there's fentanyl, right? We already kind of looked at that, talked about that. I don't care who you are, you do not know your guy that well, right? You don't know your dealer that well. Your dealer is not a chemist or a pharmacist. They don't know how much fentanyl you're getting. You don't know how much fentanyl you're getting, right? So that $5 dose we talked about earlier is called a button or a bean. And if you buy 5 of them, each of them is going to have a different amount of fentanyl in there. And we don't know which one's going to be the lethal dose. How do they mix it in? On their kitchen counter, in their bathroom, right? It's all powder. They shove it in some pills. They weigh it. They sell it. So the other question here sometimes is why? A couple things here happen. One, about 5 years ago when fentanyl first came on the scene, people were scared. They avoided it. And then what happened is the tide shifted, because then if you found out that someone died, that's what you wanted, because you thought it was stronger and might get you high again, right? But having talked with users and people who use heroin and fentanyl, most of them say, I didn't get higher, I just passed out faster, because it slows down your respiration rate faster. So the reason that people are doing it, dealers are putting it in, is because it's more cost effective and it's cheaper. So heroin has, per kilo, a street value of about $65,000. Fentanyl has a street value of about $5,000. So it just takes a little bit to go a long way. And the other thing that's now happening within the last about 6 to 8 months is that they're now putting fentanyl into cocaine and methamphetamines. So people who don't even use heroin are overdosing from fentanyl. So in case it's not here, it may be coming your way. Most people start snorting, then smoke, then inject. And that's always the search of trying to get higher and trying to get it into your system faster. They don't get there, but they try to. But chemically, they don't ever get there again. It just happens faster. So mixing with other substances, we were actually talking about this before we began tonight. If you think outside the box here just a little bit, not necessarily about illicit substance users, but about people who are on prescribed medications. So we actually do a whole different training curriculum with medical providers. So we've been like at Mercy and at different medical clinics, or at the Wish Clinic where they work with pregnant women who are on medication for opioid use disorder. And we're talking about not necessarily just illicit substance users, but people who are getting prescriptions of opioids. So the ask is that the medical personnel start to co-prescribe naloxone, which is Narcan, and that anyone who has a lot of opioids and benzos like Xanax, because they're at risk for an overdose. So here's what that means. That means if you are on prescribed opioids like Vicodin, Percocet, or Oxy, you take your prescribed medication as directed, and you have anxiety, so you take your prescribed Xanax as directed, and you are on trazodone because you don't sleep very well, and you take that as directed, and because you're a grown adult, you have a couple beers before you go to bed. Those are all central nervous system depressants, and you are at risk for an overdose. The problem is those folks don't identify with the word overdose, because to them, overdose is about junkies. So what they will say is, I've never overdosed, but my wife called 911 3 times last year because I stopped breathing, which was an overdose. So what they identify with are things like side effects of their medication. So we do a lot of education about how to word these things with people who are not illicit substance users. Okay. Along with that is that respiratory illness. So if that same person also has COPD, emphysema, anything where their lungs are at risk, that also puts them at risk. And then using alone is also a risk factor, because then no one can call 911 or use Narcan on you. Any of these things could or may be present. They don't all have to be there. Slow, shallow breathing. They could be blue, cold, clammy to the touch. They could have this gurgling or snoring sound. You'll hear this kind of talked about as the death rattle. They won't be woken up, teeny tiny pupils. This is a bad visual. Ignore the picture. If they're doing this picture, give them the Heimlich maneuver, right? But the point is they could have that choking sound. So I actually had a parent who I talked to who said she thought her son was literally choking on his Cheerios because she heard that gurgling, choking sound and didn't know that that was a symptom. Or I hear stories all the time about, I checked on Johnny before I went to bed, I opened the door, I heard him snoring, in the morning he was gone. Because what they heard was that, but he was only doing that 4 or 5 times a minute. That boils down to 3 really easy things. The person is unresponsive, you call their name, shake their shoulder, maybe do a sternum rub, and they don't wake up. They have ineffective breathing. I don't talk about respiration rates, because when I do, I start counting my own breathing, right? So if they're not breathing often enough or deep enough. And then those teeny tiny pinpoint pupils. That's the only way they're going to get this small, is in an opioid overdose. So questions on what that opioid overdose looks like. If I stop at the gas station on my way home tonight, and there is a person in the bathroom who is cold and clammy, they don't respond when I shake them, they're not breathing very well, are they having an opioid overdose? Probably, possibly, exactly, right? Maybe. Do I give them Narcan? Because I'm going to have it on me.
Sure. Yes.
No and yes. Yes!
Not gonna hurt them.
Absolutely, it's not going to hurt them. Thank you. So let's talk about that. Perfect answer. I never get that many yeses. So I'm about 95% sure I said Narcan and naloxone interchangeably tonight, right? Because most people say the word Narcan. Naloxone is the generic, like ibuprofen. Narcan is a name brand, like Advil, right? So naloxone has one purpose, and it goes to that same receptor I've been talking about in the brain. It goes to that mu receptor. It's called a competitive antagonist. That means it fights for its position. So it will go to that receptor and fight off any opioid and take the place. Just for clarification, someone once said to me, I'm so glad somebody invented Narcan because of the opioid epidemic. Naloxone's been around forever. Kind of got it started in the OR, like if your anesthesiologist got a little carried away, That's what they used, right? It hit ambulances like 50 years ago, so they've had access for years. It's just now making its way into the hands of lay people, okay? So general public is just now having access to it. So there are 3 versions that you have access to as a non-medical professional. The intramuscular, so that's a vial with naloxone in it, a syringe and a needle that you put into the muscle, either the thigh, the shoulder, or the butt. There's the Narcan nasal spray, which we're going to talk a little bit more about. And then there's this Evzio auto-injector. It's kind of like an EpiPen. It talks to you step by step, tells you how to use it. Since we're going to talk about cost, let's talk about cost. These are all 3 the same medications. The intramuscular, if you go buy it cash in hand, is about $20. The Narcan nasal spray is about $100 to $150. The Evzio is about $4,000. So I will say that after the Surgeon General came out with his advisory that everybody should have naloxone, they made a movement to be more affordable. Evzio did. And they said everybody who has private insurance can get it for free. So I followed the link and went, and you have to print out this form. You have to take it to your doctor has to sign off on it, and they will mail it to your house for free. They do still bill your insurance the $4,000. So keep that in mind. If you buy it direct from the manufacturer, I think it's like $360. So it's still very expensive for most of us.
What's the life of those different?
All of them are about 2-year shelf life. Yes, sir?
Do you build up an immunity to Narcan?
Good question. No. So that's kind of one of the rumors that happens is, especially on social media, people talk about Narcan-resistant heroin and fentanyl, and that there is no such thing. So it doesn't matter if you have been given Narcan 5 times. It doesn't matter if you use Vicodin, heroin, or fentanyl. If you get enough naloxone on board soon enough, it will always work. The key here is that heroin overdoses happen in minutes to hours. Fentanyl overdoses happen in seconds to minutes. So if you find someone 5 minutes into an overdose and they have fentanyl on board, it may just be too late. But it will always work if you get enough on board soon enough. This is just a visual of the 3 kinds of naloxone that exist. This is that intramuscular, that's the nasal spray, and this is that auto-injector that's crazy pricey. So I just want to talk about legalization about naloxone in the state of Missouri because a lot of people worry about liability. Back in 2014, the state of Missouri allowed any emergency responder to carry naloxone on them. So that's why our training started with police and fire, because that's who was allowed to carry it at first. So in August of 2016, the law was passed that anyone, any person in the state of Missouri can have, possess, and administer naloxone. And you have complete immunity. You cannot be arrested, charged, prosecuted, and your licensing board cannot come after you, whether you are a nurse, a counselor, a social worker, whatever licensing board you answer to, you have complete immunity. If you administer naloxone with good faith and with reasonable care. So that means that person I mentioned earlier in the bathroom, you believe that they're having an overdose because they met the criteria, so that's with reasonable care. You administered it the way we're about to talk about, so the way that you're supposed to. And then the other caveat is you have to call 911, right? So that's what gives you that immunity, is that you called emergency responders to the scene. If you are an emergency responder, you don't have to call 911. Anyone can give someone naloxone, and they're not going to get in trouble for it if they believe the person is having an overdose.
Does the adequate care, does that include the storage of the naloxone?
Sure.
The concern that we have is keeping it in our car.
Yeah, because you can't.
Because you can't.
Yeah.
But if you take it out every day and inadvertently forget to grab it when you start your shift and you run into somebody, then are we then negligent because we don't have it?
No. And there's also nothing in legislation about if you're there and don't administer it, because police who are resistant will ask every question possible, right? Because some officers believe that this is not their job, and I'm talking extreme examples here, but some believe like survival of the fittest, this is people who made bad choices, whatever happens, happens, this is not my duty, right? In answer to that, we've done some research. I am not a lawyer. let me administer that, right? But I will say legislation does not say anything about if you don't administer it and you have it. Just like, yes, it has a shelf life of 2 years. It's supposed to be kept at room temperature. It can do excursion temperature. So if one of your traffic lights goes out and you're on light duty for 3 hours and it's 100 degrees, it can go with you and stay on your body up to 107 degrees, right? So it can do some excursion stuff. But if you forget it and you don't have it, then there's nothing in legislation that says that. So if you want, email me and we can give you the legislative pieces, if that's helpful. And our project coordinator is a legal guy, and he can connect with you guys about that stuff too.
Policies or anything?
Tons of them. And I don't think I have this in here, but the MORE project is, they are training rural police agencies and providing naloxone for free. So I can get you connected. Okay. I'll get you connected on that stuff too. Good questions. Okay, the last piece is August of last year, there became a statewide standing order. So what that means is anyone in the state of Missouri can go to any pharmacy in Missouri and purchase naloxone and use your insurance. Anyone can go buy it cash in hand. I already told you the prices for that. If you have insurance, you can go to CVS. You can say, I would like to purchase naloxone. They use your insurance. You don't have to have an outside prescription. You don't have to go to the doctor first. That statewide standing order kind of allows the pharmacist to use your insurance like a prescription, and you just pay your copay.
Any age?
Any age.
I mean, because if they're starting to use this at 12, a 12-year-old go in, I mean, I know this is...
Yeah, if they have insurance, or you as the parent or the aunt or the whoever could go, right? Absolutely, and it can be administered to anyone. Anyone can use it, carry it, administer it. It can be used on any age.
The standing order probably is per pharmacy policy. The Walgreens might require the Walgreens.
Yeah, I could see that, I was just thinking,
So you just put it right.
Yeah, the standing order is statewide, but each pharmacy does its own thing. Since you mentioned Walgreens, I'll mention them too. And say that some pharmacies, you pay your $35 copay, that's what it is for me, and they send you on your way. Some pharmacies have you fill out 10 pages of paperwork and identify a patient's name. Some pharmacies do not. CVS, Walmart are easy. Walgreens, not so much. That's their own internal policy at Walgreens. I'm going to talk about the Good Samaritan Law. Here's where this August 28th of last year, Good Samaritan Law statewide in Missouri was passed. Love that. Yes. One of the last states in the nation to pass this too, right? So there's lots of legal jargon up here. What it says is a person who in good faith seeks or obtains medical assistance for an overdose or other medical emergency has some immunities. They cannot be arrested, charged, prosecuted, convicted, or have property subject to civil asset forfeiture for the following crimes. And then we'll circle back. Possession of a substance, possession of paraphernalia, keeping or maintaining a public nuisance, alcohol sale to a minor, possession of a fake ID, purchase or possession of alcohol by a minor, violation of a restraining order, or violation of probation and parole.
Does that cover the person that overdosed?
So, what this means is the person who sought or obtained medical assistance and the person who's having the medical issue. So, let's give some examples. My friend and I are using, my friend overdoses, I call 911. I have immunity, my friend has immunity. If there is a field party, there's a bonfire, there's some underage kids drinking, somebody decides it's a good idea to jump through the bonfire, gets caught on fire, that's a medical emergency. I call for my underage friend, I have immunity, my friend has immunity. There's 20 people at the party, legislation covers 2 people. The other 18 may want to scatter. Now, we do know that different prosecutors are handling this differently. So some prosecuting attorneys say, I don't care, I just want them to call and get help. Some say, it covers 2 people. So I don't know what's happening out here. Yeah.
Why was this law enacted?
So why it happened? Anybody have any guesses of why it happened?
people can dump off.
Yes, body dumping. In the St. Louis area, I don't know about here, it was so bad that at St. Anthony's, which is out in South County, they weren't even making it to the emergency room. They were being dumped at the edge of the parking lot, and security was finding them. So why would I not want to call 911 for my friend? Because I have drugs on me, because I'm high, because I'm on probation or parole. I don't want to get arrested. I don't want to get in trouble, right? So it covers kind of this possession stuff and underage drinking. It does not cover outstanding warrants or anything else. So it doesn't cover distribution, manufacture. If you overdose in a meth lab, might want to find somewhere else to drag the person, right? Take them outside, whatever you got to do. It also doesn't cover things like domestic violence. So people sometimes really struggle with this restraining order piece, right? Because restraining orders exist for a good reason. But how often have you ever known someone who had a restraining order out on someone and then they got back together, right? By choice, especially if there's drug use involved. So if my ex and I get back together and I go over to their house and they have an overdose, but I know there's a restraining order, I may not want to call because I don't want to go do 5 years, right? So I'm not going to violate my restraining order if I call the police. And the same with probation and parole, right? If I'm on probation or parole, I'm not allowed to be around people who are using. I'm not allowed to have paraphernalia. I'm not allowed to be using. Maybe I'm not even allowed to be in this neighborhood. So when I call, I cannot be violated for that. So I will say that as we have trained police over the last year, well, 7 months or so since this has been in effect, it's a slow process, right? At first, police didn't even know that this law existed. They were angry about it. It has caught on. They understand that it's happening. They're getting on board. Some are better than others. I was doing a presentation in a jail in St. Louis about a month ago, and I had a woman who got very angry, and I was talking about this, and she's like, when did this go into effect? In August 2017. February 2018, she was arrested after an overdose for possession. Right? So whenever she goes to see the judge, it's going to have to be dropped. But in the meantime, she's been sitting in jail for weeks, lost her job and lost her kids. Right? So the education piece is really important here. We have a PDF version of this card that's a little bit longer, and on the back it has the Good Samaritan language on there. We have done lots and lots of advertising pushes, so on mass transit in the St. Louis area, on social media, on radio, in print. But the biggest thing is word of mouth and getting it out there, which is why as we spread the word, we ask more people to spread the word, because people don't know. If everyone and anyone can have naloxone on them, anyone can administer naloxone. If we are providing Narcan to anyone and everyone, is that enabling people to use more drugs?
They're going to use anyway, yeah.
Okay, no, and they're going to use more anyway. And I heard some no answers. So people feel pretty strongly about this, kind of like the methadone thing, right? People feel really one extreme or the other. People are like, absolutely not, they're going to do what they're going to do. Or they're like, hell yeah, this is enabling, right? Like, I'm just casting out the safety net and I'm going to catch them when they fall. So of course they're going to push the envelope, they're going to use more. A couple examples to kind of compare it to. This is a societal health issue, right? I'm here because it affects everybody. There's a reason why we're all talking about opioids. Other similar health concerns over time are things like safe sex in the classroom. When that began, people threw a fit about it. And they were like, you're going to give my kids condoms? Then kids are going to have sex. They're already having sex, right? So now we have less teen pregnancy. If we fast forward to 2018, if we know someone is having high-risk sexual behaviors, we want to get them on PrEP to slow down the spread of HIV. So if somebody's having multiple partners, unprotected sex every single day, we want to get them on PrEP, have protected sex. We're not encouraging the behavior, but we're trying to eliminate some of the spread of disease. A couple other examples are up there, but the really important one I like to talk about is the helmet one. So they did a study of people who ride bicycles and wear a bicycle helmet. And of that study, there was a small subset of them who said, absolutely, when I wear my helmet, I ride closer to cars because I feel safer. Right? It's true. I lived in the city of St. Louis for years, and I completely believe that, right? Like, there's some bike riders who scare the crap out of me because they get so close, because I feel safer. So will there be a subset of people who may use more heroin because of Narcan? Maybe, but it's going to be a subset, right? So I kind of mentioned already in the state of Missouri that we are slow about a lot of things. So naloxone has been in the hands of lay people for years everywhere else. So they've done a ton of research east and west coast, and what they found is in communities that learned about naloxone, how to use it, they learned the risk factors of an overdose, that those people actually use the same amount, if not less, opioids after that education and those programs started. So research says people aren't going to use more. The other thing that says that is, remember that graph, right? When somebody's truly addicted, they're not getting high anymore anyway, and they know that. So part of what I do are these mini trainings in my office where I give people Narcan if they don't have access to it or can't afford it. And I had a young woman in my office who was an active heroin user, was there for Narcan. She was 26 at the time. And you know, after I got her warmed up, I said, so do you want to stop using heroin? Like, is that an option? And she's like, you know what? I've been using for 10 years. She was 26. She'd been using for 10 years. She never had a desire to stop. Perfectly okay with it. And then fentanyl came on the scene, and she was terrified of fentanyl. She didn't want to die. So she was single mom, 2 kids, no job, no insurance, no money. She's like, I would love to get into treatment. I'm on every waiting list that exists, right? She's just waiting for her opportunity to go to treatment. So I asked her, I said, you know, since we're kind of talking, I said, part of what I do is these trainings to people, and some people believe that if I give you Narcan, you're just going to use more heroin, and then I'm enabling your behavior. What do you think about that? And she kind of looked at me like I was crazy, and she's like, do they not get it? I said, do they not get what? She's like, I can't get high anymore if I try. And I said, fair enough, I get that. When's the last time you used? And she said, 20 minutes ago. She was fine. She was awake, she was aware, her speech was fine, her eyes were fine, because she was, in her words, just using enough to not be sick. So for her, the Narcan was, I don't want to die from fentanyl, not I'm going to use more heroin. And by and large, that's the story that we hear from people. Like I said, it's the brand name of naloxone. It does take about 2 to 3 minutes for it to kick in and start working. So some people picture Pulp Fiction, right? That moment, that doesn't happen. Okay, don't expect that. It is a slower wake up. It takes about 2 to 3 minutes, and it only lasts about an hour. So I think this kind of answers your question from earlier. If someone is overdosing on something like Oxy, or they have enough opioids on board, they can go back into an overdose state. So it's really important to call 911, get them to the hospital so that they can be observed by a medical professional. Okay. So if we find that person I talked about earlier, we think they're having an overdose, this is what we do. We give them 1 dose of Narcan, and we're going to walk through how to use that. We're going to call 911. We talked about why. And then, if you're able and willing, do rescue breathing. Rescue breathing is paramount. Even if you find someone overdosed tonight and you don't have Narcan on you, if you administer rescue breaths, that can be enough to save them until EMS arrives. The reason people die is because they stop breathing and their heart stops. So if you find them, let me say, if they don't have a pulse, ignore all this. Do CPR if you're trained, okay? You have to have a pulse and have circulation for Narcan to work. They don't have to be breathing, but they have to have a pulse, okay? So do rescue breathing if you're able and willing. So if it's that stranger in the bathroom and they fell and broke their nose and they have blood, safety first, right? But if it's your child, you're not going to care, right? So it just depends on, as long as you're able and willing to do rescue breathing. Stay with the person until EMS arrives. After 2 to 3 minutes, if they don't start to wake up or breathe on their own, give them a 2nd dose of Narcan. So this down here is the recovery position. So if you don't do rescue breathing, or if they start to wake up, roll them on their side. Why? In case they vomit, right? So that arm and the knee kind of act as a kickstand so that they don't roll back, so that if they do vomit, they're not going to choke on it or puke on you. This is what Narcan looks like. I'll let you guys pass this around. It comes in this blister pack just like this. And then this is a demo unit that you can kind of get a feel for exactly how it feels. If you want to pass that around. You peel the back off. It is not Tylenol cold. You don't need scissors or anything. It's just ready to peel right off. It's super easy, right? So peel the back off. And when you hold it, you're going to see there's plenty of room above your fingers. So you place the tip of the device into their nose, so the back of your fingers to their nose, and then you press the plunger. It's that simple. That's why people like this version, because it's really easy to use. No priming, no pumping, it's ready to go. So the one that you're passing around, that's exactly how it comes. There's no lid, you don't have to do anything to use it, it's ready to use. One dose, one nostril. So what that means is the kind of dummy one is really easy to push. In real life, it's a firm, brisk push because you're breaking a seal in there. So right here, there's a foil seal, and you're pushing hard enough to break that seal. That's what creates the mist. And you do one squirt. When you use it in real life, your thumb will push the plunger up and it locks into place. So that's how you'll know that you've used the whole dose. So one squirt is one dose in one nostril. After the 2 to 3 minutes, if you need the second dose, use it in the other nostril just in case there was blockage in the first. So in each box there are 2 doses. And each dose is 4 milligrams. So that's 8 milligrams total, which hopefully will be enough until EMS can arrive. Sometimes it takes more than that, sometimes it doesn't take that much. Just depends on what they're overdosing on and how long they've been overdosed. So that's just a reminder about that head tilt chin lift if you do the rescue breathing. Or even if you don't, if you can just lift their chin up, it could be enough to open up that airway. Lay people administered naloxone. So IV straight in the vein from an EMS, a little bit different, right? Or in a hospital setting, a little bit different. But the lay people administered naloxone is a slow, gentle wake up. That's why it takes 2 to 3 minutes. About half the time when someone wakes up, they just wake up. They have no reaction. About 20% of the time, they're going to be a little angry, irritable. About 20% of the time, they might be dope sick. They might feel a little withdrawal, right? They're going to hit them right back into that red zone. But waking up swinging, that combativeness, only happens about 4% of the time. So it's really rare. I also tend to warn people, it depends on who's in the room, right? If you wake up to a loved one's face, it might be different than you wake up to a blue uniform with a badge, depending on your history. So treatment, let's talk about treatment for just a minute. We mentioned medication is the most effective treatment for substance use or for opioid use disorder. Just so you know the kinds of treatment that exist in the world. Inpatient, somebody goes and lives there for about a month, right? Outpatient, they live somewhere in someone's home, whatever, and go to the facility a few times a week. And then there's some other options too. We talk about alternative approaches because sometimes someone became addicted to opioids because they have real pain, right? So they need to treat it in another way, such as chiropractic care or acupuncture or other therapies, massage, all that kind of stuff, right? And then community supports are things like AA, NA meetings, Smart Recovery, other support groups. So, how to find help. If someone were to call me at NCADA and say, I live in St. Genevieve, where can I go? And be like, I don't know. What I'm going to do is I'm going to pull up the SAMHSA locator, right? And then on that SAMHSA locator, that's what we use for anything that's out of the St. Louis area that we're not sure about. And you go there, you type in your zip code or your town, and it will list everything around you geographically. And it'll say the type of treatment, whether it's mental health or substance use, where they do both, what kind of insurance they take, all that kind of stuff. Right? So it's pretty easy to access. Or you can call them if you're better on the phone. And then this is your kind of local number down here to call for any kind of services and referrals. Oh, I mentioned this earlier. This is the Missouri State Targeted Response Grant. It's the STR grant. This came out about a year ago. It is a 2-year, $20 million grant specifically for medication for opioid use disorder for people who do not have insurance. So if you are uninsured and have an opioid use disorder, you can access treatment through this grant, and it is free. There are different places covered by this. Every single day they get more places on board. So if you go to their website, you can look and see on a map or by list who is covered and who is on that grant and accepting patients. And their primary goal is to get people on medication, like we talked about earlier, with methadone, buprenorphine, or Vivitrol. Specifically for uninsured.
Are there waiting lists?
No. That's the whole point is to get them in, get them in, get them in. Now, I will say their goal is within 48 hours. Reality is less than 2 weeks. Better than 6 to 8 weeks that it was before. So within a couple weeks you can get somebody in. And then this is the one that I was mentioning earlier. This is the MORE project. It just started a few months ago, and they are training and educating specifically emergency responders in rural areas and providing them with free naloxone. So I think our team trained them about a month and a half ago, so they are live and going. So anyone who needs emergency responder training can go through them, and they'll do that for free also. I mentioned NCADA services. Even though I don't know this area as well, we're not that far away, right? So if somebody can get to St. Louis, we can do in-office assessments and referrals. So if someone isn't sure if they have an issue, they need to talk to a professional, they can call us Monday through Friday, 9 to 5. They can come into our office for an assessment, and then we can get them connected with whoever they need to get to. We also, like I mentioned, do that free Narcan training in the office if somebody doesn't have insurance and needs Narcan. And I brought pamphlets on that too. And then photo op, if anyone's interested, it's our website, all of our social media stuff, my contact info. The last thing I wanted to talk about is Talk About It, STL.com. This is NCADA's newest campaign. The idea here is to get upstream, right? So this is prevention. This is how to talk to kids about alcohol and drugs, kindergarten all the way up. You download free talking kits here. Everything on it is free, and it's a guide to how to talk to kids. So starting in pre-K, it's what are good things that you can put in your mouth? What are bad things to put in your mouth, right? Stuff like that, all the way up to, then it's an age group, like 3rd through 5th grade, how to have those kinds of conversations with kids. Because the idea is we need to prevent it for future generations, right? And sometimes having those conversations can be really hard, especially if we're not used to doing it. So I also brought some yard signs with us as part of that campaign that say addiction can happen to anyone, and to talk to your kids. We know that if you talk to your kids about alcohol and drugs, it reduces their risk of addiction by 50%. So it's really important. No stupid questions, right?
So I remember heroin as a kid,
Yeah,
and then you didn't hear anything about it until 2010.
yeah. What happened?
Do you attribute the resurgence? I've heard theory.
So, okay. 2010, what happened? What happened in this country? Marijuana in this country became legal in many states, right? Way back when, most of our heroin came from over there, right? Came from the Middle Eastern countries, right? That's where all the opium stuff was coming from. Now most of our heroin comes from Mexico, because what happened was early, mid-2000s, okay, really long story short, early 2000s, late 90s, we got the 5th vital sign. Sorry guys. 5th vital sign happened, pain, you go to the doctor, you leave with a smiley face or a frowny face. If you don't leave with a smiley face, your doctor doesn't quite get reimbursed what they want to be reimbursed. So people want to leave happy, which means they leave with pain pills.
You have the right to be pain-free.
Yes,
No one's ever pain-free.
correct. Because in this country, we don't believe in pain, right? So that's part of this perfect storm. The other part of the perfect storm is Colorado and Washington State started growing the best weed in the country and in the world. So Mexico no longer had to supply us, so they ripped up the marijuana fields, they planted opium poppy fields. And here came the heroin, which is why it switched. It switched from this heroin that wasn't super strong to this heroin that was amazing. If people call, I mean, I don't know how many people a day I say who are like, I'm ready, I need help. And I'm like, I'm sorry, you're going to have to wait. We don't have funding.
Money.
We don't have funding. If you have private insurance, I can get you into treatment tomorrow. If you have Medicaid or no insurance, I can't.
It's just a
And
shame.
that's
that
across the
prices
board, it's
stay
mental
the
health all
drugs.
across the board, it's not just substance abuse.
Sure.
Does Medicaid pay for Suboxone?
Yeah. And Medicaid pays for Narcan. By the way, copay for Medicaid for Narcan is $3. They go to the pharmacy with Missouri Medicaid. So Medicaid has some decent coverage, and people get reimbursed for Medicaid.